So, welcome back, everyone. Kristina Skarbinski is going to present challenging cases. She is a nurse practitioner with MGH-GI. She specializes in neurointestinal motility and gastrointestinal surgery. And she is also the lead advanced practice provider of the SHID program at Mass General. So, over to you, Kristina.
Thanks so much. Thanks for allowing me to participate. And I just wanted to start off by saying these are just challenging cases that I found were very interesting in my practice. And I'm also going to talk about how I incorporate both the medical and the surgical sides in GI and GI surgery throughout each of these cases. So just a old picture, but a goodie. This is just an example of some of our team members just really collaborating and working together. And then I wanted to give a big plug for the SHED Center. It's really a great team full of multiple providers who just really collaborate together and work together to make sure that the patient gets a complete and thorough evaluation as well as a holistic approach. So the first case that I have here is a 67-year-old male. He has a past medical history of arthritis and hypertension. His BMI is 27, so a little bit overweight, but generally normal. No past surgical history and no allergies. He's had over 3 years of intermittent dysphagia to solids, and he describes feeling food getting stuck in his upper chest every few months, usually in restaurants, and he usually has to excuse himself to go to the bathroom to induce vomiting for relief. And I just want to take a quick side note just to say that this is kind of what we call steakhouse syndrome, where you'll notice, or hopefully you never have to notice, that someone's running to the bathroom urgently, ready to get rid of whatever impaction that they have. And it's usually with things like this man here: steak, chicken, pasta, and sausage, so solid foods, as well as just anything that can really, get stuck in the esophagus. So liquids alone were without any problem. He denied any type of GERD symptoms, such as chest pain, heartburn, acid regurgitation, or food regurgitation. And we really wanted to distinguish this because a lot of times patients will say, oh, I feel like something gets stuck and I vomit. And sometimes they actually mean regurgitation. So it's really teasing that out to understand, is it a forceful vomit? Do they induce vomiting? Is it spontaneous? Or is it something that just effortlessly goes up into their mouth? And for this man, he has to induce vomiting to alleviate the impaction. So he was seen by both GI and GI surgery, and he was ordered for some further testing. But I do want to say that prior to seeing surgery, he had, over those 3 years, a number of tests. And when he presented to us, he was just really frustrated. He, just really wanted to know why this was happening. And he's had so many tests. So back in 2016, he had an upper endoscopy. The esophagus was normal, as well as the stomach and duodenum. He had a dilation with a savory dilator with no resistance at 54 French. That particular endoscopist didn't tell us if there was any post-tissue disruption, but also a couple of years later, he came back for another upper endoscopy. He did note that there was a non-obstruction Schottky ring, and that was at the GE junction. And again, they dilated without any resistance, but with a 51 French, and there was no notes of any type of post-tissue disruption. Everything else looked otherwise normal. What's interesting is with the Schottky ring, sometimes it can be associated with some reflux. So that might be something just to keep in mind when you see this on an endoscopy. He also had a barium swallow. It showed moderate to severe esophageal spasm in the mid to distal esophagus and some luminal narrowing. And a 13 millimeter barium tablet hung up temporarily in the distal esophagus, but eventually cleared with water and extra sodium bicarb crystals. And just a quick side note, the reason why we say 13 millimeter barium tablet is because that is the diameter of the esophagus. So we want to mimic a food bolus going through the esophagus as best as we can, so that we can understand what's happening in real time. And then in October of 2018, he proceeded with an esophageal manometry. This was done at an outside hospital and showed normal LES relaxation, but there were multiple instances of panesophageal pressurization consistent with spasming, but did not actually meet strict criteria for type 2 achalasia given his normal LES relaxation on the manometry. So from our team, since his prior manometry did kind of give us this not clear picture of, maybe it's type 2 achalasia, et cetera, the surgery and the GI team both agreed that we need to proceed with something almost like a tiebreaker testing to say, hey, is this truly achalasia? So we proceeded with the upper endoscopy with endoflip testing, which everybody's heard many times throughout this day, especially from Dr. Velez, who's and several of our providers who are really well versed in this testing. But basically, they determined that his clinical his diagnosis was consistent more with type 2 achalasia. And that was, if you look at the DI with the distensibility index, it was lower than 2. So it did show some abnormalities. So I just want to take a pause here. I just want to ask any of our panelists here if they would do any other testing in this instance, or if they feel comfortable with just proceeding.
Yeah, so I think that's a good question, Kristina. And it looks like this patient already went through such extensive workup and good workup. Yeah. Especially when there's some sort of diagnosis of achalasia, I'm always like considering like, should this patient be considered for like a POEM or be further evaluated for POEM? So I think that would probably be my mentality or like next step, like should at least this person get an evaluation with an advanced endoscopist to see if this is something that they could consider in the meantime. That'd probably be my route in the meantime, just to make sure it's covered, they know their options and see if it's something that's beneficial.
Great. Anyone else?
I would say that I'm surprised that the patient hasn't ever had an esophageal biopsy to date in any of those endoscopies, or maybe they did, but it wasn't, he's 67, he's not your standard patient for eosinophilic esophagitis based on age, but I've been fooled before. And so before considering POEM, I would certainly consider just taking some biopsies proximally and distally.
100%, I agree. Yep. So actually he had ended up, so I want to just kind of, the team felt that he was appropriate for achalasia diagnosis. And I just want to pull up a nice table here just from prior gastroenterologists who wrote out, what we could do for each of the types of achalasia. So for type 2, as you can see, the most recent in the Gastroenterology Journal in 2013. So they note that pneumatic dilation and myotomy tend to have good results for type 2, although I would argue now, even with the POEMs, are good for type 2 as well as type 3. But usually we reserve Botox injections for people who are in their 80s or who are not quite sure, or if they're not able to undergo a surgical intervention. So this patient actually ended up going through with a lapellar myotomy with a door fundoplication, so a 180-degree wrap in June of 2019. He did have a normal postoperative recovery. He followed a postoperative diet. He actually said, you know what, I feel 20% improvement with my swallowing, and I still feel like foods are getting stuck in my chest, but maybe on a more weekly basis or monthly basis instead of on a regular daily basis. And he usually now can avoid vomiting, which is an improvement, with hard swallows or just waiting it out. He denied any type of GERD symptoms, weight loss, coughing, chest pain, or abdominal pain. So in this situation, again, now what? What would you do next? I still agree with you, Ben. I really do. I think down the line, I have to say we did end up getting an endoscopy with for EOE for biopsies, but he was negative, thankfully. But anybody else have any other thoughts in this situation? He's after surgery, he's like still having problems.
I would probably consider getting another manometry at this point.
Good. Okay. So, and then, other medications that you might want to try. Anybody have any thoughts about medications?
I'd probably actually go more on the dietary aspect too, just to make sure like his diet's adjusted. I know diet is a huge thing. So even anything post-surgical, you want to make sure that they're following or being compliant with the diet. So I'd probably go more the diet route and then sort of see if any medications could be added to that if needed.
Right. Okay, good. So we end up proceeding with a barium swallow. It showed prompt emptying of the tablet, which is different from his prior study, which showed a hang up. And then the barium contrast passed through fine. There were some surgical changes noted, which we expect. We actually proceeded with a modified barium swallow just to make sure, because he was having more upper feeling of things getting stuck. and that was normal. He had a repeat manometry, and that showed a normal LAS tone consistent with treated achalasia and a mix of failed swallows and fragmented peristalsis. And then we also, we presented him at our Foregut multidisciplinary conference, and we decided to undergo a Bravo pH study off acid suppression because with his history of prior Schottky ring, and just, making sure that GERD was not, a factor, and he had normal pH study. And there was poor symptom correlation with any reported symptoms, although they were minimal, and his endoscopy was completely normal. So at this point, we decided that he had more of a functional dysphagia status post the surgery. So at this juncture, we wanted to approach him with a neurointestinal GI approach, and using functional GI disorders and how we treat them, was something that, we wanted to explain. So basically, these are related to visceral hypersensitivity, which means that there's a problem with the way the brain and the gut connect and how they converse or connect with each other. And there's inappropriate pain perception or unidentified contraction abnormalities. And I think we really have to hone in on this clear evidence that there's no actual obstruction on the testing that we can see, even though he's complaining that it's still happening on a regular basis. So what are functional GI disorders? So according to the International Foundation of GI Disorders, it's generally these cannot be diagnosed in a traditional way. So there's no actual inflammatory, infectious, or structural abnormality that are commonly used. You can't use a certain type of test to understand. You kind of use tests to use it as a diagnosis of exclusion. Problems occur with nerve endings or muscles and do not function in a coordinated fashion. And so we use the term sensitive esophagus, GI, visceral hypersensitivity is the main diagnosis. So what we do is we use a three-legged stool approach, and that often includes medicines, complementary and alternative medicine, and cognitive behavioral therapies. I know I understand that not everybody has these at their fingertips, so it's important to, do the best we can and try to be, flexible and think outside the box on what we can use for treatments. And in our hyper-specialized practice, we actually, have a lot of these opportunities available to us. So we generally say to our patients, we don't have to say there's nothing more we can do, because we usually have multiple options that we can pull out of our toolbox to help these patients. But we completely understand that in more community space setting or places where these aren't, readily available, it might be more challenging. So how do we approach treatment of functional GI disorders? I'm just going to give you some basic tips today. We could do a whole talk on this, and I have in the past, but using choice talk, taking a step back and say, now that we have this diagnosis of functional dysphagia, let's think about how we should move forward. It's really important that we tell the patient this is not something that you're just making up. It's not all in your head. You're not just, trying to get attention and find opportunities just to come into the hospital. We understand that. We know that this is an actual thing that we can treat and we want to treat. And a lot of times what I'll say to my patient is, I'm here as your co-pilot. I'm in the boat or the plane with you, and I'm giving you options. And it's really up to you to drive that vehicle to understand, to go whichever route you want to do in terms of treating your symptoms. And so generally you offer choice. There are several recommended options that we can use to treat your functional dysphagia, and be wary that in some cultures, asking what the patient's choice is actually a foreign concept. So they might not actually jump on that boat. So you might have to feel them out first. Sometimes offering a couple choices at first can be less overwhelming. And then justifying choice, there's benefits and downsides to different treatment options. Let's go through them, and you can pick out which one that works best for you. But I think that, maybe one of them might be helpful, at least at first. And then just personalizing your treatment plan, checking reactions. So make sure while you're talking with the patient, I would say read the room, make sure that the patient's not, either going down this like stressed out kind of rabbit hole, or they look like they're, upset because you're not listening to them, giving, time for them to process everything. So then option talks is the next important step, and, saying, do you know of different ways? Because, some patients actually look things up and and have ideas about their treatment plan. So understanding what their goals are is important. And then let me list those options that exist. It's definitely important that you find out, what options are they not interested in at all, and making sure that you don't push them too hard, or at least give them, a basic overview, but you don't go too much into it and force them to do it. And then describe options. We can start off with traditional medications, and then we can also consider complementary or alternative approaches, additional techniques with cognitive behavioral therapy. We can also use combinations of these, and oftentimes it's helpful to use combinations of these, and just being really upfront. So some of the medications that we use are off-label. Some of the neuromodulation, which I'll get into, have side effects, and it's important that we be upfront about those. Or if our patients are of childbearing age or would like to be, pregnant at some point, making sure that you outline the risks of being pregnant while on some of these medications is important. And then just making sure that the patient understands that this is a journey. It's going to take some time, and we often start at low doses so that they can slowly build up tolerance. And if there's any issue in between visits, that they reach out and discuss those issues, so that they don't just stop cold turkey and then they've been without a treatment for a number of weeks to a couple of months without any intervention. And then decision talk solidifies the therapeutic alliance. So what would you like to achieve with this? What are your goals? Did I answer all of your questions? All these are, therapeutic responses to a discussion with the patient. And then, what do you think might help you reach your goal? Is there something that I can do differently to help you feel more comfortable with our treatment plan? And then moving to a decision. So it seems like, based on our discussion today, you're interested in A, B, and C. So, and then giving those the resources to move forward with that. And like I said, making sure that they provide symptom updates, and if there's any issues with the treatment plan, that they're open about it, and don't wait until their next appointment to let you know. So medication options that we generally used, again, they are generally off-label. We use their side effects as well to improve symptoms. So functional chest pain, we can use things like trazodone, venlafaxine, SSRIs, and TCAs. Trazodone and TCAs, even the other two, venlafaxine, SSRI, I generally get a QTC or an EKG, especially if the patient is over age 65 or on multiple agents, or if there's a history of cardiac problems. If somebody has difficulty sleeping, I tend to use things like trazodone or TCA. And SSRI, if somebody's more on the constipated side and you want to kind of kill two birds with one stone, you can use an SSRI. Things to be thinking about, constipation as a side effect, dry mouth, sleepiness, and things like that. And always ask about mood changes. Globus, this particular resource that I have listed below mentioned an SSRI. Sometimes we use things like gabapentin, always being mindful of serotonin syndrome and making sure that the patient is aware of those side symptoms and to be able to report them. And if anybody has a lot of times with functional GI, there might be some hypervigilance and symptom-related anxiety. You might want to consider an SSRI or an SNRI. There's some chronic abdominal pain, you might consider an SNRI associated, as well. So again, looking at the same side effects and making sure that you take care of the patient in regard to those as well. So trazodone, I generally start between 25 and 150. I'll be honest, I've gone as low as 12.5. It's very hard to do because you have to chop the half tablet in half too, and that can sometimes be a disaster because it will crumble, but you do the best you can. TCAs, I really like nortriptyline. A lot of our providers that we work with tend to go with amitriptyline. I'd say be very cautious with amitriptyline. It's the strongest of the TCAs and can also cause the strongest side effects. And I usually don't use them for patients that, I usually don't use amitriptyline for patients over the age of 65 or even over the age of 60, but nortriptyline, dizipramine. I like nortriptyline because you can use a liquid dose and go as low as 2 milligrams for patients who are super, super sensitive. SSRIs, I 10 to 40 on the citalopram. I don't use escitalopram as much as I use citalopram, but it is available to utilize. And then SNRIs, duloxetine, I use that a lot, 30 to 90 milligrams, and venlafaxine, 75 to 225. And I don't usually use clonazepam, but some providers do, and that's the dosing there that they can utilize. So the other plug I want to make is for buspirone and gabapentin. I actually use these two quite often in my practice. Buspirone might be useful if someone has some anxiety. Some studies are suggesting that it's good for ineffective esophageal motility and generally start at 5 milligrams twice a day, increase to 15 milligrams twice a day. But I also can go, at a 3-time-a-day dosing as well, especially if a patient is having symptoms frequently throughout the day. Gabapentin has been utilized for cough, as well as other esophageal symptoms or functional dyspepsia. I like this as well because I can use liquid doses and go as low as 12.5 milligrams. I usually give the recommendation to start at 25 so that I have that wiggle room to go down to 12.5. And the highest dose that I usually prescribe for gabapentin is 900 milligrams 3 times a day. And it's pretty hefty. I don't usually use it for my esophagus patients. I usually use it for patients with functional dyspepsia, at that dose at 900 3 times a day, or somebody who has like a vomiting syndrome. And then both agents are useful for functional dyspepsia or nausea vomiting as well. So other non-pharmacological approaches include CBD, marijuana, acupuncture, diaphragmatic breathing, gut hypnotherapy, cognitive behavioral therapy. Reiki has not been utilized yet, or there hasn't been really that much research on it in regards to non-pharmacological therapies, but I think it's something that we should pursue. Peppermint oil, patients like to use it. They think it's sometimes helpful. And then Gaviscon is one of my favorites because it's very soothing, especially in the liquid form, and puts a nice frothy foam in the throat area to push things down if there's some regurgitation or any GERD-esque symptoms. I usually tell my patients to avoid the mint flavor and pursue the cherry or original flavors. I do want to take a step back here and just ask, my panelists, do you have, what are some of your experiences with approaching functional GI disease in patients? Oh, you're muted.
Oh, okay, sorry about that. Can you hear me now?
Yep.
So one of the things I would say, especially this is a great list of all different sort of non-pharmacologic approaches, but it's really understand from the patient, what are their goals? Like you mentioned, what are the top 3 things? What are the top 2 things they want improved? And then kind of assess whether or how open they are to some of these alternative approaches. And one thing too to mention is, I'm not sure about this patient, but looking at their allergy list, looking at their current med list, even pre-procedure is sometimes an interesting way to kind of get a sense of what the patient's been through before.
I have the biggest challenge that patients, especially with functional dysphagia or any sort of functional GI, they want 100% relief from their symptoms. And it's really tough to sort of reiterate to them multiple times that, you may not get 100% relief, but we can adjust it depending on what you're doing at home, medications, anything like that. So that's the biggest challenge that I absolutely see in clinic, especially with post-pop and post-POEM patients.
Yeah. I also think that's where the APP can really come in and spend more time or have more frequent visits to say, hey, you know what, we're in this together. We're all a team, but, I'm here to help kind of, walk you through this process and help you kind of troubleshoot what works and what doesn't. And it's really nice.
Yes, I absolutely agree with that. Subsequent follow-ups are very necessary for a lot of our functional GI.
Sure. All right, thank you. So ultimately with this patient, he had multiple things that he tried and found helpful. So interestingly enough, and I see this is common with a lot of my EOE patients or some of my dysphagia patients, finding drinking salsa water to be helpful when eating to reduce symptoms. And he found that to be 50% helpful. And then using CBT during the moment when he felt like he was going to panic and things were feeling like they were getting stuck. He also felt that adding in trazodone 50 milligrams at bedtime added 30% improvement on top of that. And he wanted to remain on this dose and monitor his symptoms. So that was pretty good. It took a long time, to be honest with you, and a lot of different agents. We tried many, so trazodone seemed to be helpful. So on to our second case. It's a 45-year-old female with a past medical history of anxiety, depression. She had a BMI of 30 and type 2 diabetes. Presenting with concerns for belching after a lap Nissen with toupee in October of 2019. So I just want to take a step back. Preoperative symptoms included heartburn and acid regurgitation. She had an upper endoscopy that showed erosive esophagitis on H2 blocker. She wasn't able to tolerate PPIs. And she had a strong family history of esophageal cancer. And so they proceeded with an esophageal manometry as you should prior to a fundoplication and showed a normal IRP and ineffective esophageal motility. So the types of fundoplication, which I know Alex went through some of them already, but the Nissen fundoplication is a 360 wrap and taking the top part of the stomach or the fundus and wrapping around the esophagus to make an artificial valve. Or inverted valve, like an inverted nipple almost, I try to describe. And then a toupee fundoplication, 270 degrees around the esophagus posteriorly. You know, I might also mention too, there's a door fundoplication with some of our surgeons use, which is a 180-degree wrap. I just wanted to make a note that she had a toupee. So common post-operative symptoms just to be mindful of generally with these patients include dysphagia, needs evaluation if persisting after several weeks, obviously thinking about the clinical picture, BRAF or surgery failure. So, we usually try to tell our patients, if you were to down the line get an imaging for a random reason, you'll, most of the time see like a small hiatal hernia, but there are instances, where if the patient's gained a significant amount of weight over the years or had a terrible post-op experience where they were vomiting a lot, they can have a recurrence of the hiatal hernia and unwrap, or failure of the wrap, I should say. Vagal nerve injury, hypersensitivity, and abdominal bloating and dyspepsia symptoms. So her post-operative course was uneventful. She did well for a year. She had no dysphagia, heartburn, or acid regurgitation, and she developed excessive belching throughout the day. And she kept saying, I'm so embarrassed. I hate this. I can't go out and, live my life with my friends, and all I do is burp. So she proceeded with some testing, and the barium swallow showed prompt passage of the barium contrastin tablet. And post-surgical changes were noted. No hiatal hernia. Upper endoscopy was normal. Esophageal manometry is normal. And she had a pH study off acid suppression that showed no abnormal reflux. So just real quick, Alex, do you notice any other type of post-operative symptoms that, that are common that I might not have mentioned?
Sure. So I think that was a pretty comprehensive list. I would add too that sometimes initially post-op we can see patients that might have hiccups. Typically they're transient and go away within the first few days to a week or so post-op. But otherwise, dysphagia, but in the initial setting, just like I spoke about in my talk, and then sometimes abdominal bloating as well.
Yeah. Thank you. So for this patient, she had aerophagia, which is swallowing of air. And so with each swallow, we swallow several milliliters of air. So I put a little note here on theory on why for this patient. So generally we say, with somebody who's had reflux for a prolonged period of time, they'll swallow a lot to kind of wash down the reflux, and it becomes almost like a a reflex that they just don't know about. And so once you treat the reflux, they're still swallowing, and they end up swallowing a lot of air, and then they end up belching a lot because of that. So what we generally do for patients who have a complaint of aerophagia is eliminate things like gum chewing, carbonated drinks, artificial sweeteners, cruciferous vegetables, try to reduce high-fat meals to promote stomach emptying, and reduce fast eating, drinking, and also stop smoking. We also try to help them reduce stressors, and that means, pulling out some of our complementary therapies throughout our toolbox, diaphragmatic breathing teaching, which we do a lot over at the Mass General, and baclofen is also an option to focus on transient LES relaxation. And also that's helpful too for hiccups as well, in addition to other medications like thorazine, et cetera. So this study here with diaphragmatic breathing looked at a total of 36 patients, 21 were control and 15 were treated with 4 weeks of weekly diaphragmatic breathing, and they showed that greater than or equal to 50% reduction with diaphragmatic breathing in 9 of the 15 treatment patients. So that's pretty good. The sample size is small, I think, but it's just something that, we can think about for future treatments. So how to perform deep breathing exercises. I do want to put a little note in that Andrea is the first person to really bring this on for Mass General, and this is part of the handout that we give that she has done a lot of work with over the years. So, we usually use a 30 minute to visit to go over this and focus on how to practice the technique. I usually tell my patient to sit. I also find that if they're at home and you're doing virtual visits now, you can have them lay down and actually feel as they're breathing in, focusing on the belly expand and deflate to actually feel that dramatic change in the pressure of their belly. And then I usually start them off with cycles of 10 sets twice a day, although they can also practice it during the moments that they're having their, belching or hiccuping, etc. And I have them count to 5 seconds per inhale, hold, and exhale. So I do want to make a note for Andrea. What else do you tell them to do, or do you go beyond 5 seconds per inhale, hold, and exhale?
Yeah, so what I'll do is it depends on the patient, but we do generally do an inhale of 5, holding for 5, and exhaling for 10, depending on the patient. But the other thing that's important too is to make sure they know the anatomy. So one of the things actually the pediatric team had taught me was, it sounds so simple, but just to have them lay down like you described and really put it could be like a beanie baby for a kid, or whatever, something light on their abdomen so they can truly see that we want their diaphragm to move and not their chest. And so once they can get that piece, I think it's very helpful for them to kind of subsequently learn some of the guided imagery techniques.
Yeah, I mean, I find that that's probably I would say that is probably the hardest part, but also the control of the breath, because oftentimes they want to take this big deep breath in super, super fast, and then they can control the exhale, right?
Right.
But that inhale is like, you have to say, okay, relax a little bit, do it slower. And that might be the more difficult part of the exercise.
And you want them to actually practice it. So that's the other thing is, we usually have them do it right after meals, especially if it's belching or certainly in rumination cases. But I think if they're willing to do it twice a day, every day, then I'm happy, versus making them feel they have to do it after every meal and then it becomes a chore and then they won't stick with it. So that's important to really get a sense of what they're willing to do. And make sure also that they're not like an adolescent that's going into the bathroom at lunch and doing it because they don't want to do it in front of their friends. So all those factors, depending on the age of the patient, is really important.
Right. I also tell them too, your diaphragm is a muscle. And if you just did it once, say you went to the gym and you wanted to get abs, as much as we all would love to after one visit to the gym, it's not going to happen. So it's the same thing with the diaphragm. You got to practice to make it strong. So.
Exactly. Yes.
All right. Thank you. So, so she actually did well and found diaphragmatic breathing to be helpful, in addition to taking some baclofen and reducing her stress as much as she could. And she also found that dietary changes were helpful, as well as eliminating carbonated drinks. But about 6 months after doing all of this, she developed some postprandial fullness within minutes of eating and some intermittent nausea unrelated to meals without any vomiting. So in this situation, team, what would you do?
Well, with her history of diabetes, and her symptoms of postprandial fullness, I would consider getting a gastric emptying study to start.
Mm-hmm. I agree.
I also agree with the gastric emptying study. That'd probably be the number one thing I'd do. And then maybe some follow-up testing, like SIBO testing or something like that, or even just something that we can normally see in general GI, such as H. pylori or celiac, like sort of just go through that whole workup.
Perfect. Yeah. So I threw out a bunch of tests here, upper GI series. You can think about a small bowel follow through. I tend to leave the small bowel follow through for last because there's a lot of radiation that goes with this. And if you can avoid it, it's probably best. And usually the small bowel traveling slowly is not as common, but it's there. Upper endoscopy, gastric emptying scan, just make a note, 4 hours is better than the 2-hour scan. H. pylori testing, and then maybe a CT abdomen pelvis if you want to look at things a little bit deeper. So her gastric emptying study actually showed a 78% emptying at 4 hours. So I just want to make a note, for patients like this, for her, I would consider things, like prokinetics, maybe metoclopramide, liquid erythromycin, or domperidone. I don't usually use domperidone that much. It's from Canada. They have to get it, elsewhere. So it's a lot of headache, I think. So I generally use metoclopramide or liquid erythromycin. I start at 50 or 40 milligrams of the erythromycin 3 times a day, but then move on to adding a bedtime dose if necessary. I've even gone as low as 25 milligrams. Metoclopramide, I like to use the liquid version, 5 milligrams, so we can avoid as much as possible those EPS syndrome, EPS side effects or tardive dyskinesia. Procalcide is a newer medicine that we've been using. It's not new, but it can be helpful with stomach emptying and, even intestinal emptying. Neuromodulation, like we've talked about before, anything that might help with distension of the fundus and accommodation of food. And peppermint oils and methylconazine, over the counter things like famotidine are also helpful. Antiemetics, marijuana or dronabinol prescribed. Complementary therapies like CBT or gut hypnotherapy, diaphragmatic breathing we spoke about, and even acupuncture, although that can be pretty expensive. Dietary changes, I recommend gluten restriction, fructose restriction, or lactose restriction, but I really want to focus on doing one at a time and not going overboard, because sometimes that can put you down a bigger rabbit hole with, avoiding foods and then it just becomes problematic. So I generally start with a low-fat, low-fiber diet. Lifestyle changes, including small, frequent meals. Diabetes control is huge. You want that A1C to be as normal as you can possibly get it, or as low as you can possibly get it within range. And then avoiding late night eating to prevent any regurgitation at night or aspiration, and reducing, reflux as much as you can as well. Also,
I was just wondering, when you're talking about prokinetics, can you just touch a little bit upon tachyphylaxis, like how you might approach that with the erythromycin?
Very, very good. Yes. So we usually with the erythromycin, I personally do the 2 weeks on, 1 week off approach. Some providers like to do 5 days on, 2 days off. I really find it helpful to at least start with the 2 weeks on, 1 week off approach. And I tell my patient, think of your stomach as running a marathon for 2 weeks. It needs a week to relax and recoup, or otherwise it's just going to not want to do a thing and you're going to be stuck. So that's kind of how I get them to understand why it's important to take that week off, because otherwise it can, prohibit us from moving forward when using the medication because the medication will stop working. But I also think of the GI tract as a conveyor belt. So if you don't manage the constipation too, you can also have problems from the upper region as well. And then Priyanka spoke well about the GPOM and POP procedures as options, which I think are very useful in certain patients. And then SIBO treatment is huge, especially for patients with a small bowel transit issue or dysmotility. You want to think about, does this patient have SIBO? Or if they have a connective tissue disorder, you want to think about SIBO as well. So for this patient, she actually did okay with the prokinetics, and she only needed to be on them for a short period of time before she could come off of them. So that was good. So my final case, I wanted to touch on this because it was a recent case that we just saw in clinic, and I just thought it was cool. This is a 90-year-old male. He has a history of type 2 diabetes, hypertension, high cholesterol, bladder cancer, anxieties. He was presenting with his whole family as his advocates, but also he's very with it, high-functioning man who had concerns such as dysphagia to solids for several years. I mean, we had testing going back as far as 2015 with endoscopies, but he was diagnosed with type 2 achalasia on esophageal manometry in 2017 with the IRP of 20.6, and 100% of his swallows represented panesophageal pressurization. And he, over the years, received 2 esophageal dilations and 3 Botox injections of the LES, and they were helpful for short periods of times, but the most recent one in January did not help his swallowing. All of his meals were liquefied into a blender, and he lost 20 pounds over several months, but he's been stable at 180 pounds recently. But he's at this point where he's like, I can't live like this. I don't want to live like this. We need to do something else. I'm willing to take the risk. He had no pneumonia history, but did wake up at night spitting up food and thick white yellow mucus. And I just want to say, with our achalasia patients, you want to make sure that they're not having any residue or food on their pillow at night. That's huge. Or like hacking into cups. I mean, I've had patients who were literally filling up cups full of phlegm and food products. So this CT chest that we did show diffuse esophageal wall thickening as well as a patulous esophagus. And then interestingly enough, it showed a large diverticulum arising off the distal esophagus. I did show a quick photo of that. I think that's kind of interesting looking at that big pouch there. But the thought was that this was just accumulating food, and causing problems. But what's interesting about him is none of the endoscopies noted this, but barium swallows did over the years, but the CT chest really gave us a good picture of what was going on. So with this patient, as I said, no prior endoscopy. We thought about maybe doing a time barium swallow. Does anybody else have any other ideas of what they would have done?
So I think I'd consider, just because there is evidence of a large diverticulum, especially in the distal esophagus, is there any evidence of mediastinal disease? He's 90 years old. I totally get it. But at least to rule out something else, because to see a diverticulum that low sometimes can be caused by either tuberculosis or something else. So probably maybe try to test for that, maybe just to rule it out, make sure everything is okay with there too, in the meantime. Yeah,
I think that's huge. I mean, this poor man, when you think about diverticulum in the esophagus, it's usually from poor motility of the esophagus for some reason, and it could be from that, Priyanka, or it could be from just really end stage achalasia or progressive achalasia, which I think for this man that was the case. But we kind of teeter-tottered around maybe doing an esophageal manometry again, because he's had so much done to his LES. We decided not to, but then maybe, should we do an endoscopy with the endoflip? We decided not to. One of the surgeons, we actually decided, okay, maybe if he can pass the PATA test and all that, because the patient was like, I can't, we've got to do something, sir. I'm over it. And I don't blame him. I mean, it's nowhere to live, not being able to, go out to eat and things like that. But we decided to do a repair of the diverticulum with the long myotomy. Now, this has not gone through yet, I have to say. So it's just a thought process that we have. But so I think, with these patients, I think considering a multidisciplinary approach is so huge. and we really find benefit with like working as a team. And that's where I think the Shed Center really works really well to treat our patients, because we all really want what's best, and we all have different things that we can, you know, contribute to the patient. So yeah, that's it.